Thanks for joining today. I would like to acknowledge and respect the traditional custodians whose ancestral land we are meeting upon here today, the Ghana people from Adelaide here. I acknowledge the deep feelings of attachment and relationship of the Ghana people to their place. I also pay my respect to the cultural authority of Aboriginal and Torres Strait Islander people visiting and attending from other areas of South Australia and Australia present here. We have fantastic speakers today from Ans Data Registry. We have Executive Officer Professor Stephen McDonald and a postdoctoral fellow Dr. Erandi Hewawasam. You might have heard a lot about Ans Data, or if you never heard about it, this is your chance to know more about what Ans Data is. Professor Stephen McDonald is based at Royal Adelaide Hospital and is the Executive Officer of Ans Data, and his research includes registry-based trials, consumer engagement, and also improving access to transplantation for Aboriginal and Torres Strait Islander. Erandi is a postdoctoral fellow at Ans Data. She is currently working on registry research project, more importantly on pregnancy and parenthood in patients receiving dialysis or kidney transplantation, including perinatal risk and outcomes using population-based data linkage. A bit of a warning, because pregnancy and parenthood is a sensitive and personal issue for most of the people affected with kidney disease. And if the contents presented by Erandi later today, if triggers any negative emotions, I would request you to please talk to your healthcare professional regarding your care and your emotions. And we will respect your privacy, and if you feel distressed, you can leave the seminar. Thank you so much. I would like to welcome Stephen to present and share his screen. Thanks, Stephen.
Thanks, Shyam, and thank you for the opportunity to present and talk to the group today. What I was going to do is I guess just spend a little bit of time working across the breadth of things that the Ans Data Registry does. And there are a number of areas where consumers are already involved and can be further involved, and very happy to pick up those themes as we go through. As I said, I was just going to touch on a number of things pretty lightly, and Erandi a little bit later on will go into in more depth one of the areas that's been of particular focus around pregnancy and related issues. One of the things we often get asked, of course, is what do we mean by a registry, and what is a registry? And it's one of those things that I guess is a bit of jargon. The technical meaning of a registry, of course, is just a list of information, a list of names or a list of numbers. In the health sense, what registries refer to are collections of studies, or a single study that is usually, rather than a focused research study that has a beginning and end, that has an ongoing nature. And they fall within three broad groups. There are things called clinical quality registries, and that's the group that best fits Ans Data. There are groups of registries, or they're registries that are focused around a particular device or a particular drug. And so, for example, when a particular device, a new pacemaker is introduced, sometimes there can be a specific registry which is focused around people that receive that particular device. Another example of that would be breast implants. There's a breast implant registry that's run out of Melbourne, focused around people that receive a particular type of silicone breast implant, and excludes other people with other types of implants and other types of breast diseases. And then there are diseases that are focused around registries that are focused around rare diseases. And so the aims vary a little across those three groups. For a rare disease, it's really a way of understanding the natural history, whereas for a drug or a device is often focused around safety, and a clinical quality registry does a variety of things. And and certainly clinical quality registries fit into what is a broad set of organisations in and around the healthcare system, and this is what the diagram on the right of the screen is trying to to portray is around the hospital and the actual and GPs and actual healthcare hands-on delivery. There are a bunch of organisations and groups that actually operate to improve healthcare, delivering both better outcomes and better value, and that includes clinical quality registries, which overall have a role in if you like, measuring how many and what happens to particular people, work out who's doing well and who's doing less well, and also can drive some of the questions that then lead to generation of new evidence in trials. And I'll get back a little bit more to that later on. ANZDATA is the, doesn't quite stand for Dialysis and Transplant Registry, but many years ago in the 70s it seemed like a good term to use, and it is a clinical quality registry which includes all renal units across Australia and New Zealand, contribute data, and contains information about people receiving long-term dialysis and kidney transplantation, and collects data at various points along the way when for example, people have transplants, but each year at the end of the year, data is collected about some of the other indicators. So, for example, what hemoglobin levels are on dialysis and so on. There's been a fair bit of evolution over the years, and the actual data collection goes all the way back to the beginnings of dialysis and transplantation in the early 60s in Australia. And there were initially two separate registries, one for dialysis and one for transplantation, and they came together in 1977. And at that stage, of course, the hottest new technology was the phone with buttons on it, and so you can see Lee Excel, who was the executive officer for many years, with push button phone and a 5 1/4 inch diskette and a dot matrix printer. So things have changed a little bit now. And along the way, and in particular in the last 10 or 15 years, the scope of activities within and around the Ans Data Registry has expanded quite a lot. So we've picked up a number of other areas within Ans Data, and in fact now there's a group of registries. Ans Data is the largest one and acts as the core, and the organ donor registry, organ donation registry, is the other really important one, and I'll talk a little bit about more that later on as well. And then there's a living kidney donor registry and the iron tissue registry. All of these are based at SAMRI in the Cheese Grater building, and operate with the same group of staff and off the same IT system. And the funding for all of this in terms of the core infrastructure comes from the Australian and New Zealand governments via in Australia, the Organ and Tissue Authority, and Kidney Health Australia very generously also provide a contribution. Despite all those wonderful things and all the lovely architecture of the building, ultimately, of course, like a lot of things, it's basically people sitting in desks at computers, and Sham knows exactly what it looks like, and it's a nice office, but it doesn't look that different from the outside to any other office. So, as I said, the two main components of that are the Ans Data Registry, and that, as I said, collects data from renal units. It's a mixture of paper and electronic data collection, depending on what the unit want to do. Has ongoing follow-up and a combination of of ways of collecting data. The organ donor data is about in ANZDATA is about solid organ donors, and we use that term to differentiate donors of kidneys, hearts, lungs, solid organs from so-called tissue donors. So people who can donate corneas or skin or muscle after death is quite a different pathway and a different process. And as you can imagine, the consent and data collection processes are quite different for the two registries. So why does ANZDATA exist, and what do we actually do? It's not just data. You don't just collect information and data for data's sake. You actually collect it to do some stuff with it. And the remit of ANZDATA, or the aims, fall into three broad areas. And one of the challenges we have is we sort of, out of this data collection, we provide data that feeds a number of different areas and has a number of different audiences. And those audiences include consumers, they include clinicians or doctors and nurses, they include health administrators, policymakers, and the general public. But broadly speaking, the data goes to drive health service planning. Goes to feed a major quality and safety program, and they're the, if you like, the core purposes. There's also, we've been fortunate enough to be funded by the NH and MRC and some others to use that data for some clinical research to answer some questions, some new knowledge, and Erandi's going to give you in depth some examples of that in a minute, and I'm going to touch on some other areas of research as well. A lot of this stuff is available from our website, and I'm happy to direct people to there if you are interested in finding out a bit more. The annual report is a lengthy chapter, and Charm's been developing a better and more easily understood summary, but it does include a number of chapters, 10 or 11 chapters, goes up and down from year to year, which has a lot of text. It has a number of graphs. So for example, you can see how the number of new patients starting dialysis in Australia keeps going up year on year on year on year. And that's obviously a challenge in terms of health service providers. There's also a lot of information about the outcomes, and here as an example, we've got what happened, the mortality rate during dialysis, which is one of the outcomes measures, is an important one. And look, you can see some good news here in terms of the mortality rate is falling over time. That's important information as well. That's all at times fairly dense and not readily accessible information. And so one of the things we've been trying very hard to do as an organisation over the last few years is make that information more readily available. And one of the things we've been doing, and Charm's been leading this, is to create more accessible ways of presenting that information. And the infographic you can see there, which I suspect many of you have seen, and some of you may have helped design, is one example of that, about how to, if you like, have the snapshot information readily available to people without having to go trawling through the pages of the report. So that's the sort of basic data in terms of the countrywide. As I mentioned, one of the main uses of that is in health service planning. So as an example of that, one of the things we do is collaborate with governments and or do independently a number of pieces of work. So a few years ago, we collaborated with the Institute of Health and Welfare in Canberra to look at nationwide projections for the number of people that are likely to need dialysis into the future. And we're actually in the process of redoing these at the moment. And clearly this was done, in fact, it was released in 2013. And you can see that we're pretty close to the mark. We actually projected slightly more dialysis and transplant patients than ended up happening, but you can see the errors pretty small. It's less than 10%. So that's an important part of planning for the future in terms of governments and health services, knowing that there's an incoming need. It doesn't mean they will necessarily be perfect at addressing it, but it does drive the planning of services. Knowing where people are is critical, as well as knowing the total number. And so one of the other things we do is we drill down and provide some information about where are the areas in cities, and indeed city versus country, where people are likely to, or where services are likely to be required. And here's Sydney and here's Adelaide. There's perhaps less variation around Adelaide than there is in Sydney, but there certainly are areas where rates of kidney disease are higher versus lower, and that's important to know in terms of service planning. It's obviously also important to think through what might be driving that. One of the key things, these are areas, so-called statistical areas based on census districts and so on, but if you drill down a little bit further into postcodes, you can actually get into some more practical elements of it all, which is looking at, okay, well, how close are people to their dialysis units, and are people being treated where they need to be treated? And this is an example of a so-called spider plot. And what it is it has all of the postcodes around Adelaide and links the postcodes with the place where people are receiving their dialysis treatment. Some of you are from Adelaide will recognise the geography, others of you won't, but Adelaide's a very long and spread out city. So this is Gawler up in the north and Noarlunga down in the south, and the Adelaide Hills are around the outside here. So Adelaide tends to be a sort of long, thin city. But the important thing from this is it really does illustrate the fact that there are a number of dialysis centres, but there are dialysis centres up here which need to be expanded effectively, because there are a lot of people who from these postcodes here that are actually driving down to the city and from here, and even from up here, that are going down to the city when in fact they should be being treated much closer to home. So that's an example, I guess, of the very practical end of the data that we collect. Another example of the practical sort of data that tends to get picked up a lot in government circles is looking at organ donors. This is a graph looking at the rate of organ donors or the number of transplant recipients, recognising that some donors donate kidneys, so there's 2 kidneys. Some donors donate kidneys and liver. There are some donate multi-organs. So on average, there's around about 3, a bit under 3. Or recipients per donor. But what you can see, of course, is that the going from 2016, 17, 18, 19, the organ donor rates were improving, and then in 2020, of course, they fell back, and it's a little bit clearer on this graph over here why they fell back, and that is over the March and April and May last year. There were very few organ donors, and the reason for that relates to COVID, and then the line runs parallel. And this year, of course, things have continued slow. So what that is an illustration of an ongoing, if you like, slightly reduced organ donor rate related to COVID, and we need to understand better what that is. So that's the sort of health service planning side of things. Just to touch on some other things, safety and quality. So we provide a variety of safety and quality reports for individual hospitals, and there are summary versions of these that are available for the public on the website. In theory, the clinicians and doctors look at them, digest the information, and where it's got messages for them, then they can make changes inside the report. There's a bunch of information about how one particular hospital's group of patients is similar or different to the national average, and this is an example of the Adelaide report. And then there's a number of ways of presenting so-called outcomes. So if you look at the transplant outcomes for the unit in Adelaide, we're bang on the national average in terms of, using this example, the rate of graft loss at 1 year. So you can understand how this is a really important metric. As a transplant unit or as a dialysis unit, we do want to understand whether we are performing at or better than the desired. And there's a bunch of other metrics that we produce, peritonitis rates and so on. So that if you like is the stuff that comes out from the core of ANZDATA. And that the audiences for that are predominantly health administrators, clinicians, and so on. And around all of that, there's a bunch of research and other activities. And I'm just going to touch on some of these areas, and then hopefully lay the introduction for Erandi. So talk a little bit about some of the observational research, and then trials, and then but first of all, I'm just going to talk a little bit about some work we've done around the National Indigenous Kidney Transplant Task Force, and that was driven by some work within ANZDATA. And one of the things we did is look at the rate of people getting onto the waiting list, whether they were Indigenous or non-Indigenous, and the driver for this was the observation that there were markedly fewer Aboriginal people receiving transplants than non-Aboriginal. And the question then is it a problem getting onto the waiting list or getting from the waiting list to the kidney? The answer is the difference is getting onto the waiting list. When you get onto the waiting list, the rate of getting onto transplantation is very similar. There's a marked difference there. It's an early difference. That difference is greater if you are older. It's greater if you live in a remote area. So this was an interesting and research finding. It's one that's of course very relevant, and together with the Transplantation Society, we went and spoke with the AOTA and then eventually with the Minister, and that led to the setup of the Kidney Transplant Task Force, which we also host here in ANZDATA, which has got a bunch of things running, some data collection, running a number of pilot programs around the place, and looking at so-called cultural bias or institutional racism is another term that might be acting as blocks to access to transplantation. So that's an example, I guess, of how we've used the data to translate through to some changes in care and more to come. Other areas, we're working with other registries to look at how care patterns differ. So to use this example, we've done some data linkage with the Joint Replacement Registry, which is another clinical quality registry that's next door to us, showing that dialysis patients have a much higher rate of hip replacements, which reflects some of the disease, and a much lower rate of knee replacements. Other areas we've been involved in are, of course, looking at COVID. And one of the concerns about COVID was and still is, happily things are settled down in Australia at the moment, but was that it might very severely affect dialysis and transplant patients. And that certainly actually has been the case overseas. So we added in March last year some new data around COVID, and if you look at the pattern that we observed, so firstly, this is the general population, and those of you thinking back last year will remember there was a lot of cases in around about 12 months ago in March and April last year, and then everything settled down. And then Melbourne, there was a big Melbourne outbreak, and then that all settled down. If you look at where and when the cases were among dialysis and transplant patients, they largely mirrored that population, and that's reassuring. What's even more reassuring is to know that the rate of getting them, the rate of getting COVID was pretty similar to the general population here. So there were, to the end of last year, or at least the beginning of December, there were 13 dialysis and 20 transplant recipients that had COVID. And the SIR is a standardized incidence ratio. So what that says effectively is it's basically the same as the general population, no more and no less. Just in the interest of time, I'm just going to skip over that and just finally touch on the link between registries and trials. And I mentioned earlier on this circle here. So registries are really good at observing things and drawing links and making novel observations and raising questions that need investigation, and also following patterns of care and working out whether things have changed. What they're less good at is, if you like, working out whether a particular intervention, a new drug or a new technique, whether that actually is truly effective. That's traditionally been the realm of randomized controlled trials, which are done differently, separately. One of the things we've done in recent years in combination with the Kidney Trials Network based out of Brisbane is to combine and run a number of so-called registry-based randomized controlled trials. So using the framework of the registry to run trials that are relatively cheap and often quite pragmatic, looking at things that the drug companies are not all that interested in looking at. The 4 that we've got running at the moment are something called Resolve, which looks at the level of salt or sodium in dialysis fluids. Best Fluids, which looks at whether people get saline or plasma light after kidney transplantation. Teach PD is a trial of different ways of teaching or training people in peritoneal dialysis techniques. And the SWIFT trial, which is just getting up and running this year and started in New South Wales, looks at collecting information about from patients on dialysis about how people are feeling and asking people to score their symptom burden, and then feeding that directly back to their nurses and doctors, and asking the question of if every 3 months you ask people to report their symptoms and you feed them back, does that actually lead to any change in the in people's quality of life and those symptom burdens? So that's it sounds a bit odd to sometimes when you present to people, but just asking people how they feel isn't necessarily done consistently in dialysis, and there's just asking people how they are doesn't necessarily mean that it's going to make any difference to how they actually feel. So that's the premise of that trial. So that's, I guess, just some very light or brief mentions of a number of different areas. As I said, the registry is funded by the government out of your taxes and my taxes, and New Zealand government and Kidney Health Australia. Behind the scenes, behind Erandi and I, there's a slightly larger team than that, because that's last year's photo. But there is a very substantial team, and I'd like to thank all of those, and thank all of the people in renal units who contribute their data, and of course thank all of the people at dialysis and transplant recipients who are in various ways part of it all. So very happy to take any questions or explain anything else, either now or at the end, as you wish, Sham.
Thanks, Stephen. That was a really great overview. I know it's really hard to explain registry in terms of data collection, but it was a great presentation. If you have any question, just you can unmute and ask. But before that, we will ask Erandi to present her topic as well, so that we will combine your questions and ask to both presenters today. Thanks, Erandi.
Oh, okay. Oh, can everyone see this screen?
Yep.
Okay.
Yep.
Yeah, great. Thank you so much for the opportunity to present here today. And Stephen gave a really nice overview about the Ans Data Registry and the data that is collected within Anstata. So I am going to really focus around the pregnancy side of things, and the pregnancy with kidney disease research. And I will also talk about the consumer engagement aspect of our work as well. So just to start off with, to sort of lay out the scope of what we are working with. So up to around 3% of Australian population is affected by chronic kidney disease. And from the Ans Data Registry, we know that around 26,000 people are receiving kidney replacement therapy. And this was according to the latest data that was available. And this is either dialysis or transplant patients. And out of this, there's around 7% of these people are women, 9% are men of childbearing age. So these men and women during this time will need to think about some complex and challenging decisions around parenthood with kidney disease. And from our recent work, what we are seeing is that there is an increase in the birth rates in women receiving dialysis. And in transplanted women, we see that their birth rates are much, much higher compared to dialyzing women. And the Shilpa Jesudasan and the team have done a lot of research in this area. And one of the studies was interviewing women with kidney disease about their thoughts and experiences of having children. And what they found out was that for many women, pregnancy was a challenging and a difficult decision that they had to make with the support of their doctors. It was quite an uncertain time. Women spoke of that as an important, like a high priority goal for them, and that they had to make with the support of their doctors. And what really came out from that study is that we need to really focus on prioritizing patients' views and values, and we need to understand patient experiences when making decisions about parenthood. So there is still quite a bit of things that we don't know, and we need to do a bit more studies around. So one of them is health of the mothers and babies after birth. So after giving birth, how is the health of the mothers and the babies are like? Do the babies grow up normally? And the outcomes for mothers after birth. And we don't have much details around the labor and the delivery process at the moment as well. So we need to look into that in more detail. And we need to do more research around identifying factors that might be influencing or driving various pregnancy outcomes, whether having certain comorbidities like diabetes or hypertension has an influence on pregnancy outcomes, whether the kidney function at the time of conception or pregnancy makes a difference. So these things we need to actually investigate a bit more detail and look at how these factors might influence pregnancy. And we need to do more understanding around pregnancy planning and care practices available, because at the moment there's not it may vary, and we haven't done a study to look at what the pregnancy planning and care practices available across Australia. So we need to have a better understanding around that, so that if by doing that we can then identify whether there are any gaps, and if there are any gaps then we can address these gaps. So the overall vision of our program is to really change how Australians with kidney disease navigate pathways for successful pregnancy and achieve their parenthood goals. And this is through making informed choices where patients are aware of their risks versus the benefits, and they're able to make informed choices. Having shared decision making between doctors and patients value this. Having shared decision making, and improving pregnancy planning and care. Having pregnancy planning and planning really early is really important to have a successful pregnancy. So with our pregnancy project, we are working really closely with the consumer group. This is a national consumer advisory group. So this is a group of 6 women with lived experience of kidney disease at various stages of kidney disease and at various stages of pregnancy journey. So this is a good representative group of women, but we do have plans to expand this group, and we have several other consumers that will be joining us this year, and we are also hoping to include some Indigenous women in our group as well, to represent Indigenous communities and their thoughts and experiences as well. And we normally meet sort of 3 to 4 times a year, and then we also communicate via emails and phone conversations on various different aspects of this pregnancy research. And it has been truly wonderful to work with this consumer group, because our consumers are able to share their lived experiences of pregnancy with kidney disease and really help us set up patient priorities for research, because what might be a priority for myself as a researcher is not the same priority for a consumer. So finding out what's really important for consumers and has really enabled us to prioritize those projects and those research. And our consumer group has really been involved from the very start in the study design itself, designing the study and data collection tool. So what I mean by data collection tool here is developing surveys, for example, or developing interview questions. Really has been, you know, having and being involved as co-authors in this process and co-producing this work. And has been also involved in sharing the research findings back into the community. So that's in the form of, for example, when we develop sort of like a visual summary of the findings in consumer-friendly way, so that we can disseminate our research into the community in consumer-friendly ways, so that the general public can really digest that information and take that on board on their day-to-day living. So a lot of our projects have been around the Ans Data Registry, and Stephen already gave a really nice overview around what the Ans Data Registry collects, so I won't go into too much detail around that. But since the registry's inception back in 1960s, the Ans Data Registry has been collecting parenthood information, but initially it was very basic. So basically they collected the baby's birth date and the birth outcome. But since then, there has been more and more data collected, and in 2001, a specific parenthood form was introduced to formalize this data collection process. And this captures, the Ans Data Registry parenthood data captures all pregnancy events. And that means that it captures even early pregnancy losses as well. So the parenthood, using the parenthood form, we collect these data items around pregnancy outcome, for example, live birth outcome, gestational age, birth weight, preeclampsia, which is a condition where we see high blood pressure and protein in women's urine, diabetes, fetal abnormality, which is basically birth defects, so it's a yes and a no type of question, and neonatal survival, whether the baby survives up to sort of 28 days. Again, yes and a no type of question. And then more recently, we have made some changes to this data set to collect some additional information around the kidney function and around the birth information. And for example, we have included a question around the women's use of assisted reproductive techniques, which was not included in previous data collections. So this reporting of the parenthood events to this parenthood data within Anstata is voluntary. So there is the possibility that there could be some reporting bias associated with that, but we have recently done a study, and we have validated this data collection process, and around 75% of the births or parenthood events, maternal parenthood events, are actually reported to the Ans Data Registry, so which is really, really good. There is still that 25% that is not currently being reported, but we are working to improve that actually by sort of educating our data collectors around the importance of this data set. And the Anstata parenthood data collection is not only collecting parenthood events for mothers, it also captures data for fathers as well. So if there's a male who has fathered a parenthood event, who while receiving kidney replacement therapy, so that could be dialysis or with a kidney transplant, that their details will also be captured. So we have that information as well. So with this data set, we have done quite a bit, there are a couple of studies that have been published around pregnancy outcomes in women with kidney transplants. There have been another couple of papers looking at pregnancy outcomes in women receiving dialysis. And more recently, we have published a paper looking at pregnancy outcomes in simultaneous, those who had pancreas and kidney transplants at the same time compared to kidney transplant recipients. So this is a visual summary that is an example of a visual summary that we developed with our consumer advisory group. So and we developed this for our consumers. And also we have published a paper around fatherhood with kidney replacement therapy using this Ans Data Parenthood data set. So as you can see, we have done quite a lot of studies using the Ans Data Parenthood data set, and it has really to
I just don't want to type that at the moment, that's all.
Sorry, there's some background noise I'm getting. Yeah, so this data set has been really informative and has been really internationally recognized as well, and has led to quite a number of studies. But as with any data set, there is some limitations associated with the Ans Data Registry. We don't collect detailed perinatal data. That is, we don't collect detailed information around the pregnancy and the birth event. There is, we don't also collect details around the models of care that's used by women during their pregnancy. We don't collect any information around labor and delivery. So although we collect detailed information around the kidney disease and the kidney disease treatment, we collect limited details around perinatal data. Whereas we also have other state-based perinatal data sets, so where they collect detailed information around the pregnancy and the birth event, detailed information around models of care and labor and delivery, but these data sets do not collect kidney disease or kidney disease treatment. And this is a mandatory data collection system, so any birth more than 20 weeks gestation will be captured in the state perinatal data sets automatically, so through mandatory data collection, and midwives usually do this data collection. So as you can see, there are limitations with each of these data sets, but what we have thought of doing is linking these two data sets together, and thereby, minimizing all the limitations and therefore being able to answer lots of questions that we haven't been able to answer before. So what we are doing currently, and this actually we have done already, so we have linked the Ans data set with the perinatal data set, so which is the pregnancy and birth data set that captures all births more than 20 weeks gestation in each state. And we've done that from 1991 to 2013 across 4 states. So we have South Australia, New South Wales, Western Australia, and Australian Capital Territory. And through this linkage, we have been able to identify a 3 million babies cohort, birth cohort, with 1.6 million mothers. Majority were in babies who have never received, majority of the babies were born to women who never received kidney replacement therapy. But then there were around just over 1,000 babies who were born to mothers who eventually started kidney replacement therapy. So at the time of the pregnancy, they didn't receive any kidney replacement therapy, but after having their pregnancy, later on, they ended up going on kidney replacement therapy. And that was usually 10 years after the pregnancy event. And so that's an interesting group, which we haven't had before. So it's really interesting to look at that group. And so this group may have had risk factors at the time, risk factors for kidney disease at the time of pregnancy, or they may have been at the earlier stages of kidney disease. And then we had 37 babies who were born to 31 mothers receiving dialysis, and 211 babies born to 137 mothers with a kidney transplant. So the progress of this linkage study, we have published a detailed paper around the process of this data linkage, the different data sets that we linked, and why we did the data linkage, and the planned sort of analysis that we are going to do. And then more recently, we have published a paper around looking at live birth rates in women receiving kidney replacement therapy, and looked at factors that influence live birth rates in these women. So currently what I'm doing is looking at the pregnancy outcomes and outcomes for babies. And what we are planning on doing in the future is to look at kidney function and its impact on the pregnancy. Impact of pregnancy then on the kidney health, in the long-term kidney health as well, we should be able to look at using this linked data set. Long-term outcomes for babies, because the first baby that was born within this cohort would be around 25 years old. So we have quite a lot of follow-up data that is available, particularly hospital data available, so we are able to follow them up in the long term and see their growth and development. And then we'll be able to look at labour and delivery in detail, and health of the mothers and babies after their birth event. So in other words, looking at their long-term outcomes. And we are also doing a few other studies, just briefly. We're currently doing a Women's and a Partners Family Survey. This is to look at get a bit of understanding around women's thoughts and experiences on pregnancy, education, information needs and preferences. And so anybody with kidney disease, and those who are receiving dialysis or with those who are with the kidney transplant can also complete this survey. And you don't necessarily need to be pregnant currently. If you could be planning a pregnancy, you could have had a pregnancy in the past. We would really like to hear from you, because this will really inform us in developing some resources for helping patients navigate parenthood with kidney disease. So at the moment we have received around 70 responses, and we are hoping to get to like 100 responses. And there's also a survey for partners and carers, and it's a much shorter survey. It should only take less than 5 minutes. And we only have received a very few responses, like 7 responses. So it would be great if you have other partners or family members, or you know some other women, please feel free to forward this on to them. We're also doing a kidney doctors interview study where we are interviewing doctors to find out their perspectives and their experiences and their counselling practices, and whether there are any barriers to having various pregnancy counselling conversations. And these studies will nicely complement each other, and at the end of these two studies, what we are planning on doing is developing a toolkit for both women and clinicians to help both of these groups to help in providing that pregnancy counselling and education. And finally, there's quite a lot of information available on the Ans Data Registry's website under Parenthood with Kidney Disease. There's some recent updates that we have done. For example, you can go here and click on the visual abstracts, and the visual abstracts are there, and with the link to the journal page. So there's you can click on that and look at the paper itself. There's also a link to the newsletter that we have recently published in December last year that has some other resources as well. And then there are some videos, short videos that you can have a look as well. Okay. And finally, I would like to sort of leave you guys with this quote from a kidney transplant recipient. So research is required for people living with kidney disease who decide to embark on the journey of pregnancy. Early pregnancy conversations between healthcare professionals and their patients help plan for successful outcomes for both patients, their partners, their baby, and their kidneys. Early pregnancy conversations help to alleviate patient worries, concerns, and the way a topic is discussed by healthcare professionals, and that can really impact consumer experience. And finally, I would like to say a massive thanks to Associate Professor Shilpa Jesudasan, who is leading this body of research in pregnancy and kidney disease area, Professor Stephen McDonald, who has had invaluable input into this work and has provided lots of guidance. Dr. Chris Davies, who is our biostatistician at the Ans Data Registry, and our wonderful consumer advisory group, who has been really wonderful to work with and has provided invaluable input on all of our projects. Finally, if you have any questions at all, please feel free to get in touch with me on the contact details provided here, and I'm happy to take any questions as well. Thank you.
Thanks, Erandi. Thanks for showing your work to our consumer group. Now, I would like to open the floor if you have any questions for Erandi or Professor Stephen McDonald in terms of registry or the project that you heard today. You can just unmute your microphone and ask the question, or you can type as well.
Sham, I might ask a question if I may. Thanks so much for the presentations, Erandi and Stephen. My name's Amanda. I'm a carer of a teenager with kidney disease, and I'm a living donor, so I'm featured on one of your graphs somewhere along the way. I actually had a question about COVID, unsurprisingly, and how much information you're able to collect through Anstata about COVID. Obviously, you presented information about patients who had suffered from COVID. I'm also specifically asking about vaccinations and whether you're able to track that or planning to track that.
Sure, yeah, so it's a really, really topical question and a good one. So yes, we are planning to track it. The way we're planning to track it is not directly but indirectly, so that there's an Australian National Vaccination Register that basically everybody who gets a vaccination in the whole country is going to have that recorded, and there's a number of reasons for doing that, and you can imagine what they're going to be. I would imagine in the future, even time we want to get on an aeroplane to go overseas, you're likely to need that. So that the pathway that the plan is to go down is to do the data linkage thing. Erandi gave an example of that in the pregnancy space, but to link through to that. The reasons for that are that for some people, some areas, so for example, dialysis patients in some areas are receiving the vaccinations through renal units, but in a lot of other places, many transplant patients, many dialysis patients, the vaccines are being given by general practitioners or other ways, but not through the renal unit. So it's a very bitty piece of data to collect that way. And so after some discussions, we thought the more reliable way to do it was to, if you like, get it from the source.
Thank you.
So, but very, very topical question. It does work, certainly in dialysis patients. There's the evidence about transplant patients isn't in one way or the other yet, but I'm in London early on, very sadly, there are a number of outbreaks among dialysis units where you can imagine dialysis units, it's very easy to see diseases transmitted back and forth. And one of the things they've done very early is go out and vaccinate dialysis patients there very early, and they've seen a dramatic drop off in hospitalizations.
Hi, Erandi and Stephen, they were wonderful presentations. Thank you so much. I really love the short summarized versions and snapshots that consumers have had input into designing, and I think that really our kidney community would really benefit from that moving forward in regards to how we can circulate and I suppose push out these summary guides to renal units and to waiting renal clinics and things like that, and how we can actually spread the news, because unfortunately it's not just us eager kidney patients that come and partner with you, but we really want to get this information out to the masses. But I do have a question in regards to the data sets, because data sets and registries are often quite stagnant, I suppose, pieces of information. I'm just wondering how real time you think that the future might become, Stephen, with registries.
Yeah, So look at the organ donor data I showed you was up to date to February, and the only reason it wasn't up to date with March is that I made the slide a month ago, and we've got the March data. And the reason it's up to date is the organ donor system has a single national system called the EDR, the Electronic Donor Record, and it's all connected and funneled straight through to us. So, yeah, so that the world of hospitals, dialysis, transplant is much more fragmented, and even if everybody was using an electronic medical record, they're using umpteen different types. So one of the challenges we've had thinking, okay, well, we should be able to get a lot of data electronically much more quickly, is there's a lot of different interfaces, all sorts of different coding systems. Some people collect gender as male and female, other people collect gender as 3 categories, other people collect gender as 4 categories. All really important social stuff. At a pragmatic sort of data collection level, that creates all sorts of problems. And that's a very simple example. So you're right, the cross-sectional survey is getting better as we get more and more electronic. But it still basically takes 6 months to get most of the data in and another 3 months to tidy stuff up. Some of the really time-critical data we do turn around very quickly, so transplant rates, peritonitis rates and so on, we do send directly out to units every 3 months, the reports for the last 3 months. We don't release those publicly. I'm happy to circulate them to this group, but the reason we don't put them out on our website is that the numbers are often a little bit different to the final numbers because they're provisional numbers, and a few years ago we just created confusion when we put some of those things out, and people say, oh well, look, this document says there's 1,000 and this document says there's 973, and the answer is the 973 was in earlier in the year, and it was the original data. But you're right, we do try and get the time sensitive stuff out on time. Big picture stuff in terms of the projections of dialysis activity, for example, or the outcome stuff, that's less time sensitive, and honest, there's not a big push for doing that more quickly. And the answer, a long answer to a short question, Amber, but yeah.
Thanks, Stephen. Thanks, Amber, for the question. I think we are reaching the end of time, but it's a great session, and I would like to thank Erandi and Stephen for their time, and also for people attending after us. And one of the main aim of the session is to educate consumer about what's happening across kidney area, not only in terms of research, but registries. Last month we heard from clinical trials, and the next one will be our own guidelines. If you need more information about the stuff that is presented today, as Erandi explained, please visit www.anzdata.org.au, and there is a For Patients tab. You can go there and you can look at all these infographics, the consumer survey that Erandi is pushing to get more input from not only people who had pregnancy or who had a kidney disease. If you are women or a partner, please fill out those surveys. And there are infographics that, as Amber said, it's not only we are collecting data, we are producing these consumer-friendly outputs so that if you have a kidney disease, you can compare with your peers, or you can get a snapshot of, in Australia, what's happening. How many people prefer hemodialysis? How many people prefer peritoneal dialysis? What's the transplant? How many people get a transplant from a deceased donor? I think it's a well-rounded system, and as Stephen mentioned, the data collection takes a while, but there are huge amount of people working behind it. I am fortunate enough as a consumer to be involved at Ans Data Registry, not only sharing my lived experience, but also working with some of the most passionate consumers around this area. So thank you so much for your time, and I'm looking forward to meeting you in the next meeting. Thank you.
Thanks, everyone.
Thank you.
Good night.
Thanks so much. It was great. Bye. See you,
Thanks.
Steve.
Bye.
Bye. Bye.
Thanks.
Nice
Bye.
to see you again, Amber.
Bye. Nice to see you too. Bye.